Yes, we can.
You're seen.
Hi, Shiv Shankar, how are you?
Hello, sir. Fine.
I'm sure you can now hear me also.
Yeah.
Okay, fine. Thank you. Okay.
So you can check the PowerPoint presentation. You can save the screen and check once, sir.
Okay, so I'm just going on to my PowerPoint presentation. Is that okay?
Yes, sir.
Can I make it full screen? Does it become full screen for you?
No, sir. We can't see.
Can't see your presentation, sir.
Okay, now just tell me one thing. I'm on the PowerPoint presentation and the
Go
icon.
to share screen, sir.
Sorry?
Go to share screen.
Share screen. Now that is something where exactly on the PowerPoint is it?
No, it's not on the PowerPoint, it's on the Zoom. At the bottom, you see a green box with a upward arrow.
Zoom link, sir.
Just a minute. Huh?
Where there is a mute stop.
Yeah, there's a share screen. Yes. Sorry. There is a share screen.
Yeah.
I've clicked on that. And now
select the window. The
share.
PowerPoint window.
Okay, the PowerPoint window.
And start your PowerPoint presentation, sir.
Share. Is that seen now?
Just coming. Yeah. You can start that this thing, sir.
No, I'll go on to the full screen now.
Yeah.
So that is available on the bottom, this thing, right?
Yes.
So.
Yeah, that one. Perfect.
Yeah.
This becomes correct?
Yeah, you can just go ahead with 2 to 3 slides, sir.
Yeah, that I can go on.
Yeah, done, sir. You can close it. Yes.
Correct. So now I just have to what? Do is minimize it.
Stop share screening.
Stop share screening. Okay, slide control. New share.
From the same.
Correct?
No, it's not stopped, sir.
Stop share.
Yes,
correct?
done.
Okay, fine.
And
so
mute. And mute yourself. Yeah.
Sorry, I'll mute myself, right?
Yes, sir.
Yeah, when the presentation starts. Others' presentation start.
Yeah. Hi, Kitu.
The third speaker, sir, Mr. Kishore, sir.
Yeah, he's coming. He's logging in.
Okay, sir. Okay, because he's not seen.
No, he's on call. So actually, we got several head injuries today. So he's texted me. He's logging in.
Okay.
He's a good guy. The senior. I'll introduce him once he logs in.
Registered.
So I think he's today busy writing consents.
He's always.
Emergency consents.
No, we don't have to consent patients in emergencies.
That's good.
So we'll start at sharp 8:30, sir.
Yeah.
So that absolutely
we'll have a good amount of time for discussion.
Yeah.
Now we are around 13 people who are participants at present. So we have 4 more minutes.
Yeah, sure. You can wait.
And we will, I think, take discussion and questions at the end of everything.
Yes, I think that will be better.
Yeah, otherwise, in between, this discussion will just go on, and then next speaker will not get enough time.
Absolutely.
Borobar. Yes.
Yes, sir.
So we'll be in time, sir. Like all the speakers, let them be in time, so that there will be good discussion at the end, sir.
Correct. Yeah. Let's do that.
Shashank sir is not there. Dr. Shiv Shankar, have you spoke with Dr. Shashank sir?
Yeah, I spoke with him today.
But he is not logged in yet.
Just give him a call.
Yes, please.
You should be here 5 minutes, 10 minutes beforehand. Shouldn't have to call him, Shashank.
Kishore, you are sitting in UK, right?
So Dr. Matthew had joined.
नाही रे पण समजा शशांकला वेळ लागत असेल तर कळवायला पाहिजे ना की वेळ लागतोय.
येईल रे तो वेळेवर येईल अजून काळजी नको करू. He'll be dot on time.
Right. let me introduce Matt. Can you hear us?
I can. Good evening, everybody. My name is Matt Sanders. I'm one of the senior registrars in Sheffield working for Mr. Chowdhury.
Good evening. Good evening.
So how are your head injuries doing today?
No, yeah, they are still in Northern General, Matt. Two of them are dead. One is having his femur fixed because his femur has ripped through the femoral artery and he's got a bad head injury. So I've already seen them at Northern, and you haven't heard about them, have you yet?
No one's called me yet, no.
No, because I've been there in Northern today. So there is one head injury who might need an ICP monitor. There are a couple of them probably will be dead before they get to us.
Dr. Shashank will join soon, sir. I discussed with
Okay.
him.
Let me introduce everyone. This guy you see, Nitin Londe, Matt, is the man who showed me how to do burr hole first time in my life in 1985. I was a medical student then,
Remembering.
and I took inspiration from him. And rest of these guys, Jaydev Panchawak, Sarang Rote, Shivashankar Marajake, Ashish, they're all very good surgeons or qualified practicing in the state of Maharashtra nearby and near Mumbai. And thank you very much for joining us, the Maharashtrian group of neurosurgeons. And it's a pleasure to have you. And guys, Matt Sanders is one of our best senior registrars who is in his final years of training. And we are looking forward to him joining as a consultant colleague very soon. And these are the guys, Matt takes consent most of the times for all my tumor vascular patients when he's in theater. And I thought he would be the best person to speak rather than me talking about it.
It was a real pleasure to meet you all. Thank you. Thank you very much for the invitation, Mr. Chow. I'm really looking forward to it. Thank you.
So it's 8:30. Should we start?
Yes.
Yes.
So, as a secretary of MCNS, I welcome you all to the this year MCNS webinars. Dr. Shivshankar Marajake will be the convener throughout the 3 years now. So we had a MCNS update. So on 5th of the March, we had a first EC meeting, and the next MCNS conference will be held in the Kolhapur from 28th to 22nd, and Taj Gateway Hotel will be the venue. There will be one award added on this conference for the innovations in neurosurgery. Then two new committees we will be forming in coming 2 months. One is for the endoscopic spine surgery, one is for the neurointervention. It is for the propagation and promotion and awareness in public for this specialty in neurosurgeons in Maharashtra. And we will be continuing with our same website management team. Kolhapur conference audit yet to be received. So this is all the update. Dr. Shivshankar, should we proceed with the webinar? You can take over.
Yes, sir. I think it's the time now. We'll go ahead, sir, without much of discussions.
Please.
Dr. Jaydev sir will take over, and the first presenter, Dr. Nitin Londe sir will start, and then we'll go ahead with the questions at the end.
Yeah, so I invite Dr. Londe today for the first talk. And, when we were planning this webinar, I thought that a lot of concerns were voiced at the ICCN, that is International Conference of Complications. And everybody said, hello? So everybody said that consent needs to be looked at, to prevent the complications further. So let us start with the first talk. And Nitin Londe is a highly accomplished neurosurgeon, and he's also a lawyer. Is it right? Do we call you lawyer or advocate, Nitin?
No, I think we should call myself a neurosurgeon primarily and a lawyer, because to be an advocate, you require a registration, and one cannot have two registrations simultaneously.
Okay. So let us start with this first talk. How does the judiciary look at our consents?
Thank you.
Varna. Varna. 8:30. You can join. Okay.
Yes. Am I seen on the screen? Am I audible and seen on the screen?
You're audible and a screen is seen. I'm not sure it's your screen.
I see. I'll again go into the share screen
Okay.
and I'll click on my presentation. And am I seen now at least?
Yes.
Something is seen, but it's not the screen which I want to show.
No, click on the PowerPoint icon at the bottom and on the taskbar.
Yeah, there is no PowerPoint icon as
There
such.
is P. There is P written there at the bottom on the taskbar next to Microsoft Edge. Yeah, that one. Yeah, if you
Am I
click on
seen
that
now?
and now, yeah, and go on the presentation mode. So the one on the right, not that one. One on the right. Yeah, that one. Perfect.
Correct. Thank you, Kishore. Thank you very much. At the outset itself, I would like to thank all the organizers for having given me this opportunity to share my views on the topic. The topic of today is consent, and the subtopic on which I am to share my views is how does the judiciary look at consent. So going directly to the topic itself, prior to 1947, that is prior to even our independence as such, during the Second World War, a lot of atrocities were committed by the German Nazi regime. And as a result of that, there was a Nuremberg trial, which all of us know about. And during this trial, the Nuremberg Code was established. And in this code, it became mandatory to obtain voluntary and informed consent of human subjects prior to any form of medical trial or intervention of the patient per se. This same outlook was subsequently reiterated in the Declaration of Helsinki, and that was adopted by the World Medical Association in 1964, and that made it mandatory to have an informed consent from the patient prior to any form of treatment or any form of intervention of the patient per se. And then, of course, subsequently, various other international conventions and declarations came up with it, and that made consent mandatory to the procedure itself. Now, having said this, how does the Indian scenario look at consent? Now, let me bring it to your notice that consent was initially defined in the Indian Contract Act of 1872. And that defines consent as when two parties agree on the same thing in the same sense. What is important is the same sense. This is also known as consensus ad idem, and this forms the basis of an informed consent. In our Indian Constitution, Article 21 guarantees the right to life and personal liberty. And the right to life and personal liberty is interpreted also as the right of personal autonomy, wherein the patient can make a decision or a choice of how to take care of his own body. And therefore, in this fundamental right to make a personal choice about their lives without undue state interference, as long as the choice is not violating any laws established by the state. And then the Supreme Court of India interpreted this Article 21, the right of personal autonomy, as the right to privacy, reproductive choices, and the freedom to make the decision about one's body. Therefore, under the civil law, a non-consensual interference into the body of a person can either mean assault or battery, and this comes under the heading of trespass of the person, which is punishable by law. Now, in the Indian scenario, again, the laws which deal with consent, as I just informed you, the Indian Contract Act of 1872, Section 13 defines what consent is, which we just saw in brief. Section 14 defines what is pre-consent, which we shall see in a short while. And Section 11 defines who is competent to contract or give consent. The other law which determines or which has some bearing on our consent is the Indian Medical Council Professional Conduct, Etiquette and Ethics Regulation Act of 2002, in section 7, subsection 16, it insists on written consent. Then again, the Constitution of India in Article 21, in protection of life and personal liberty, the personal autonomy of the patient is protected. And now, in the Bharatiya Saksha Adhiniyam 2023, which was previously the Indian Evidence Act of 1872, section 57, it deals with consent which is accepted as primary evidence, and its form in written form, electronic form, or digital form is also elaborated in that particular section. Therefore, consent, though it can be implied or expressed in oral, written, or in sign language, it is accepted as evidence either in written form or electronic form. Now, who can consent? Primarily, it has the person himself, and he has to be legally competent. That is, he has to be an adult, he has to be sane, and able to understand what the proposal or the surgery is. If, for some reason, the person himself is unable to give consent, then who is the next person? And this is defined in the THOTA, or which is also known as the Human Organ Transplant of Tissue Act 1994, where the near relative, which is very specified in that, it can be the spouse, the son, daughter, father, mother, brother, sister, grandfather, grandmother, grandson, or granddaughter. What is important to note is that in-laws are not mentioned in this as near relative. Therefore, when we are dealing with a patient who may be a recently married woman who's brought for some neurosurgical intervention, the consent other than that of the husband has no meaning. Regarding the in-laws I'm speaking, if at all, for some reason, the husband is not available there to give consent, apart from the patient, then one has to call someone from the original family side member to give consent. It can also be a legal guardian, which the patient has primarily initially given the authority to, or it has to be by the permission of the court. Again, what is the age of competence to consent? Section 11 of the Indian Contract Act defines who is competent to contract, stating that every person is competent to contract who is of the age of majority, of sound mind, and not disqualified from contracting by any law to which they are subject. Now, this majority means 18 years and above under the Indian Majority Act of 1875. Sound mind is self-explanatory, and what is meant by not disqualified by law is that if a person is a convict, then his consent has no meaning. If at all a convict is to be operated upon, then one has to seek consent from the judiciary for operation on that particular person. Also is the fact that if the age of majority is 18 years and we are going to operate on a person who's below 18 years, preferably if the person is 12 years and above, the consent of that person in addition to that of the parents should be taken. Now, what is validity of consent? Validity of consent means that it can be enforced by law. And for that, validity means it has to be a free consent. The definition of free consent is given in section 14 of the Indian Contract Act. It is more of a negative definition. That means what is free when it does not have elements of 1, that is coercion, 2, that is undue influence, 3, which is fraud, 4, which is misrepresentation, and 5, which is a mistake. Now, of all these negative attributes, what is more important for us is the second factor, which is undue influence. The reason being is that if the consent is taken after the patient has been given pre-medication, then that comes under influence. And therefore, if at all consent has to be taken before surgery, it has to be taken before pre-medication is administered. Also, the counseling should be done at least 24 hours before. Now, consent, as we have seen earlier, can be implied consent or express consent. Express consent can be in the written form, it can be in the verbal form, or it can be in any other pictorial form. But more important, it has to be either real and informed. When we say real consent focuses on the validity of consent, which means that whatever are the guidelines laid down by law while taking consent have been completely followed. And therefore, it becomes a valid consent, which can be enforced by law. However, the judiciary nowadays, apart from validity, expects that the consent is not just real consent, but is also an informed consent, wherein it emphasizes that the patient has understood before giving consent what is going to be done with the person and what are its subsequent effects on the person's life and thereby on autonomy. And this is what is presently legally essential. Thus, informed consent, as I just suggested, that consent simply means agreeing to something, whereas informed consent implies that before agreeing, a person shall be given all the necessary information about the situation, including the potential risks and benefits, allowing them to make a fully conscious decision based on their understanding of the details involved. Essentially, informed consent is a more robust form of consent where the person is fully aware of what they are agreeing to. So understanding of the procedure and its implications to the patient has to be understood by the patient before he gives the signature of consent. Now, as far as the Indian, how do you document consent? Now, as far as that is concerned, the Indian Medical Council, Professional Conduct, Etiquette, Ethics, Regulations of 2002, in section 7, subsection 16, have suggested, or rather have made it mandatory, not suggested, that before performing an operation, the physician should obtain in writing the consent from the husband or wife, parent or guardian in the case of a minor, or the patient himself as the case may be. Now, digital consent or signature is valid under the Indian Evidence Act, but it is not mandatory under the Indian Medical Council, this Act of Regulations 2002. In an operation which may result in sterility or impotence in neurosurgery in some procedures of the spine, if at all, then provision for divorce is there under the Hindu Marriage Act. Therefore, consent of both the husband and wife need to be taken in this sort of a situation or a procedure which may involve the possibility of sterility or impotence. Now, coming to the main outlook of what the present discussion is as to how the judiciary sees this. Whenever judiciary considers the possibility of a consent which is under debate, it applies these 4 tests or rules. The first being the Bolam test, subsequently the Bolitho test, then the Canterbury rule and the Montgomery rule. We shall go into that now. The Bolam test basically is a test wherein the court suggests that if the peer group accepts what is being told to the patient and what has been conveyed to the patient as a part and parcel of consent, then it is acceptable to the law. Now, this was ratified, or it was more put to application in this Jacob Matthew versus the state of Punjab, wherein, as per the statement which was given, the death of one Jivanlal Sharma had occurred due to carelessness of doctors and nurses concerned to the empty gas cylinder. Dr. Jacob Matthew, who was treating the patient, the magistrate of Ludhiana framed charges under section 304A of IPC, which is death due to negligence. The accused appellant cannot be proceeded against this particular section on the parameters of the Bolam's test. That is what the Supreme Court ruled in this case. And this was the beginning as to how consent would be looked at by the judiciary. Though it started off with the Bolam test, however, it was subsequently replaced by the Bolitho test. Now, what this Bolitho test is that it started off with one Bolitho versus City of Hackney Health Authorities, and that test suggested that even if the medical body suggested that whatever was taken as consent was acceptable, it is for the judiciary to decide whether that particular consent stands the reasonable man test, wherein that it means that the patient has been informed about all the possible complications related to the surgery before he signs on the consent form. And therefore, there was a shift of how the court looked at the particular consent taking from just mere information to whether the patient has understood what he is signing upon. And therefore, the Bolitho test subsequently replaced the Bolam test. However, the most important case in Indian case law is this Samira Kohli versus Pratibha Manchanda, which was decided in 2008. Now here, it is an interesting story of a woman who had given consent for a diagnostic laparoscopic test because she had dysmenorrhea. However, when she was under anesthesia, undergoing this diagnostic laparoscopic test, Dr. Prabha Manchanda found that the uterus, ovaries, and fallopian tubes were all involved with endometriosis, and therefore she decided to remove them. But since the patient was under anesthesia, she took consent from the mother of the patient who was outside the operation theater. As it stood that after the surgery, this woman who was engaged to an army man, the army man refused to marry her because he said that I cannot proceed with the family now. And therefore, then she sued the doctor for it. But the pretext was that she had suffered premature menopause, necessitating prolonged medical treatment and hormone replacement therapy. As a part of that apart from making her vulnerable to health problems in the way of side effects. So the implications for this particular case in neurosurgery is that whenever we take up a patient for surgery, if at all we plan to do something more than what we have already informed the patient, unless and until we have taken that in writing in the consent, it would not be justified to go ahead with it. And more so, just to give an example, it is like if during doing an angiographic procedure, if coiling or stenting is also planned, then that has to be consented for by the patient. Similarly, in cases of spinal surgeries, if we are intending to do discectomy, root canal decompression, and fixation, then it is essential that we take consent for everything separately during the same procedure, and the patient should be informed about it prior to surgery. It should not be just that decompression is the procedure that will be done, and then we go ahead with doing decompression, fixation, or also interbody fusion and things like that. So all that has to be properly explained and consented for by the surgeon. Now, the next thing is that this Canterbury rule, all material risks associated with the proposed medical procedure has been informed to the patient prior to making the decision. This is something which is subjective to what the surgeon feels are to be the likely complications associated with the procedure that he is going to perform. I know that there can be some procedures which are very simple, they may carry very little risk, but the risk has to be tailor-made to the patient. For instance, if we have a patient, as probably will be discussed in the subsequent talks, a simple case of a subdural hematoma, but a recurrent chronic subdural hematoma in an elderly person who has cardiac problems, who has diabetes, who has got hypertension, who is also on anticoagulation, who also has renal problems, maybe has pulmonary insufficiency, the risk goes much higher. And in such cases, even for a case of subdural hematoma in such a patient, it would be essential or prudent, I would say, to inform that there's a possibility of or risk of mortality also. Though it may not be anticipated, but it should be informed, because in that particular case, if it is a young person, it may not be expected. But if it is an elderly person with all these associated risks, it can be a possibility. And therefore, that part should be properly informed to the patient. So all material risks should be informed to the patient. Secondly, subsequently the Montgomery ruling, which has also been accepted later in 2015, apart from not only informing the material risks, we also got to inform the alternative means of treatment for the particular case as far as allopathy is concerned. I'm not talking about other modalities of treatment, but whatever are the allopathic other modalities of treatment need to be informed. And now, discussing the same issue of subdural hematoma or chronic subdural hematoma, even if one may not agree to or one may have different views about what sort of procedure should be done for a case of chronic subdural hematoma, embolization of the middle meningeal artery is now a thing which is coming into practice quite frequently for recurrent chronic subdural hematomas. So that needs to be informed. Whether you perform it or not, whether the patient consents for it or not is a subsequent issue, but it needs to be informed. And therefore, this particular case of Samira Kohli versus Prabha Manchanda has a significant impact on how the consent is looked at by the judiciary. This is another aspect of our consent, which may not be a routine aspect, but it is mandatory in clinical trials, that is audio-video consent. And the standard operating procedures for that have been given by the ICMR, which is the Indian Council of Medical Research, and it has been laid down in its directives of November 24. The page numbers I have just informed you, 138 to 147. Now, this is important for those who are conducting clinical trials. And the further details about that is that, again, the same thing as what is standard for any operative procedure, the consent has to be an informed consent. It is more applicable to the hospitals wherein there is this implementation of the Prime Minister Jan Arogya Yojana, because in that it is mandatory to audio-video consent taken for conditions like for procedures like even angiography, laparoscopy, endoscopic procedures, which require pre-authorization. Otherwise, they will not get the necessary reimbursement after the treatment of the patient. Though, of course, the procedure may not be considered as being illegal without consent if taken only on written consent, but for the purpose of this pre-authorization, for the purpose of getting the reimbursement, it is essential to have this audio-video consent. I presume that that should be a fair eye-opener into how the judiciary looks at consent. And thank you for your patient listening. Hello.
Hello.
Was I audible?
Yes, yes, yes. Very much.
Thank you, Nitin. We will take questions at the end of the entire, all the lectures.
Yeah. So I'll stop my sharing.
Yeah.
Yeah, stop, sir.
Yeah, I'll do that.
Shashank had joined, no?
Yes,
Shashank
yes.
is there?
Yeah, he joined.
Yeah,
Yes.
I'm there.
So Shashank, you can start sharing your screen.
Yeah.
Yeah, so Shashank will be speaking on the guidelines for the neurosurgeon specifically tailored about the things which should be included by and large in taking consent. So Shashank, please start your lecture.
Dr. Shashank, your screen
Yes,
is not.
yes. Yes, yes, yes.
Please go to share screen and.
Yeah. Are you able to see?
Yeah, it's seen. Your
Yes.
audio also it's seen.
Yeah.
Go to slideshows. Yes.
Yes.
Yes, perfect.
So, good evening, everyone. I'm at the outset, I'm thankful to MCNS for allowing me this to speak about guidelines for taking a consent. So, why consent? Medical indemnity crisis in 20th century were almost negligible or absent as compared to current scenario, where we are regularly facing or seeing the medical legal problems which have been taken by patients to the courts. Nowadays, doctors are confronted by inconsistent and conflicting demands of the society. On one side, they expect the doctor to be available 24/7 at one single phone call. They want emergency treatment on emergency basis and all attention. But on the other side, they are not understanding the limitation part of the medical fraternity. With the development of neurosciences, patients' expectations have been skyrocketing. However, not to forget, treatment sometimes become more traumatic than the primary disease itself. And definitely as a neurosurgeon, we all know that it is uncertain and unpredictable to know which patient. Unfortunately, upon undesirable results or complications, patients have started utilizing their legal rights and remedies despite signing an informed consent. Dr. Londe sir has already mentioned the definition of medical consent, so I don't go into it. So the history of medical consent has as a roots and origin almost 3000 years BC. And we all have taken Hippocratic oath during our internship, where physicians, as a physician, we have to respect patients' autonomy and confidentiality. Primum non nocere is the most important principle which was mentioned by Hippocrates in his oath. And in modern era, Nuremberg's Code and Declaration of Helsinki have become a beacon for medical management or taking consents. So basically, the medical consent has 4 parameters, which are the pillars, like common law and Roman maxims on one side, criminal laws on other side, then constitution, law of contract, and precedent, that is case laws. So Londe sir has already mentioned about rest of the things apart from case laws. So I will like to share few case laws so that it will be interesting to know how evolution of consent has happened. So Indian contract, according to Indian contract law, it is the contract between doctor and patients. So consent is a document of contract between doctor and patient. So Solmendorf versus Society of New York Hospital. This was the case almost 110 years back, where the fact was patient was admitted to the hospital to evaluate stomach pain and diagnosed to have a fibroid tumor. Physician recommended surgery, which the patient declined. But however, at that time, there was no CT scan, MRI scan, or sonography available. So examination and anesthesia was a preferred diagnostic method. During the procedure, doctors perform the surgery to remove the tumor. Unfortunately, this lady developed gangrene of the left arm, which ultimately required amputation of the thumb fingers. So she blamed the treating surgeons for a negligent surgery and filed suit against the hospital. So what court has to say in this case, every adult human of a sound mind has a right to determine what should be done with his or her own body. In this case, surgeon perform an operation without patient's consent, which commits a battery and assault. This is true except in cases of emergency when patient is unconscious or when there is no one to provide consent and the surgery is absolutely essential. In this case, the doctors were not made a party and the only hospital was made a party, and the hospital was a non-profit hospital. So the employee of the said hospital cannot be sued. So this is the Solmendorf rule, which is still utilized in India. Then this is second case where Salgo versus Leland, Stanford University, 1957, where one of the cardiac surgeon was seeing Mr. Salgo, who was suffering from vascular claudication, and the clinical diagnosis of stenosis of abdominal aorta was made. So the patient was taken for aortography using sodium urocon, and the diagnosis was confirmed. But while taking the angiography, they have taken one or more views, as we are regularly doing for DSAs, and the patient woke up with paraplegia. So in this case, the judiciary took res ipsa loquitur as a important legal maxim. That means a thing speaks of itself. So in this situation, they don't expect any explanation from the treating doctors. And this is clear-cut case of a gross negligence. So what judges have mentioned is that whenever the physician violates his duty to protect his patient, shall subject himself to liability. And this happens if he withholds any information which is necessary to form a basis of an informed consent. Likewise, the physician should not minimize the knowledge, dangers of a procedure or operation in order to induce his patient's consent. So it is very common practice in India. कुछ नहीं होता है, nothing will happen. I remember one of the patient who who flown from US simply for anterior cervical ACDF procedure. When he was given all the possible complications explained by the local neurosurgeon, and out of all that, he was scared of hoarseness of voice. And when he traveled to India, and one of our neurosurgeons suggested nothing happens, and it was a C6, C7 disc. So unfortunately, he developed hoarseness of voice. Luckily, the opposite side cord recovered, and the hoarseness disappeared within the span of 3 months. So there was a narrow escape for that neurosurgeon. So Canterbury versus Spence, already Dr. Londe sir has mentioned about this, but in the facts of the case this was a deep-hour compressive myelopathy, and which was leading to weakness and pain for the patient. And the patient underwent laminectomy. The risk of developing paralysis was 1%, and this was not explained to the patient. Unfortunately, patient had a fall in the hospital because there was no railing to the bed, and he developed a paraplegia and bowel bladder incontinence. So the patient was explored, and after exploration, the limb power improved. However, bladder and bowel issue remained the same. So in this case, the patient went into litigation. During the inquiry, the treating surgeon was contending that informing the risk of weakness or paraplegia would have deterred the patient from undergoing surgery. So according to him, whatever he has done was in the best interest of the patient. And lower court found there is no negligence. However, upon appeal to the apex court held doctor guilty of inadequate disclosure. So during this case, there was paradigm shift of medical culture from professional practice standard to reasonable person standard. So what is reasonable person standard disclosure means? It is only informed consent. So recently, this interesting case happened in India, Vinod Khanna versus RG Stone Urology Hospital. So this 65-year-old man who was presented with pain in abdomen and retention of the urine, he was operated in the past for hernia and appendicectomy. And he was a known case of HIV, Cox, Kaposi sarcoma, and cryptococcal meningitis. The patient was catheterized and subsequently underwent evacuation of pelvic abscess. Unfortunately, this patient developed cystorectal fistula, which did not heal despite the treatment. So the patient complained to the district consumer court for 1.9 crore, and that too after 8 years of incidence. So there was no pecuniary jurisdiction. So the case was rejected by the district court, and then the case was filed in the state commission, and there was no negligence was considered by the state commission, and similar thing happened in the national commission. However, when the papers were scrutinized, they realized that there was a pre-printed consent form in the paper. So according to National Commission, the form was for any procedure, for any doctor, and for any patient. And there were blank spaces for addition of handwritten material. So according to National Commission, it was considered as an unfair trade practice, and the hospital was fined ₹10 lakh. Now the hospital has gone into appeal to Honorable Supreme Court, and the matter is sub judice. So this is another interesting case of emergency procedures. What is the role of medical consent? So husband of Mrs. Eliza was admitted to General Hospital on 11th March 1974 with the complaint of severe abdominal pain, which was diagnosed to have acute appendicitis, and surgery was advised. However, patient was shifted from emergency to ward, and no surgery was performed for next 24 hours. And on next day, the patient deteriorated and he became septic, and patient died because of perforated appendix and sepsis. So patient's wife filed complaint against doctor for negligence and asking bribe of ₹25. In this case, Dr. Thomas, who was the treating surgeon, contended that the relatives have not consented for the surgery. So any contention we make in the court of law, the burden of proof lies with us to prove that whatever has been done, there has to be enough evidence why it was done. So this case underscores doctor's ethical and legal duty to treat a patient in a life-threatening situation. So the court considered this act as a negligence, and they suggested that any emergency case, you should not wait for the patient's or relatives' consent, because whatever has been done in the best interest of the patient. So what are essential parameters of a valid consent? A doctor must take consent of the patient before commencing any treatment or procedure. I personally prefer 2 consents at the gap of 24 hours. I usually admit my patients a day before, and on admission, I take a full consent, and after 24 hours, that is on the next day before taking patient to the operation theater, the second consent form is filled, and those dates and timings are different. Consent must be taken from the patient himself, as Dr. Londe sir has already mentioned about those things. Consent should be procedure specific. That is most important part of it. Consent is nothing but a document which creates contractual relationship between patient and doctor. So consent obtained during the course of surgery is not acceptable. Another big issue is a blanket consent, which most of the patients, where most of the hospitals takes, where everything has been written. The patient has been admitted for the problems, and he will undergo some treatment, surgical, medical, and it has been blankly written that the patients and patients' relative will not hold doctors and treating hospital responsible for anything whatever has been happened. So this is the blanket consent which is completely invalid in the court of law. They suggest the fresh consent has to be taken for any repeat procedure or any postponement of the surgery. For example, if we are going to operate a case on 10th February, and for some medical reasons or fitness issues, if the case is postponed for a day or two, we have to take another fresh consent for the fresh date. There has to be a separate consent for anesthesia. Unilaterally executed consents are void. Unilateral means either the consent has been signed by only patient or signed by only treating doctors. They are not acceptable. The most important part is having witnesses in the consent. I consider 2 witnesses, one witness from the patient side and one witness from doctor's side. And patient is free to withdraw his consent at any point of time. Consent for illegal procedure is invalid. So these are essential parameters how we have to consider as a thing as a valid consent. So consent is a process and it is not an incidence. So once the patient come to our OPD, the consent process starts from then and there only. So what is the format for informed consent? There is no standard format so far up till now, but the following things should be mentioned in any consent. So date and time, patient's related information, then doctor's related information, the signatures of them, then witnesses, then disease related, where the disease, nature of the disease, natural course of the disease, any complications, and any comorbidities if they are present with the patient. If there is surgical procedure, which is more important and pertaining to us as a neurosurgeon, is what type of surgery we are doing, whether it is elective or emergency, what is nature, what is antecedent, risk and benefit, any alternative treatment available, any adverse consequences of refusing treatment or accepting treatment. So other things are like anesthesia related, blood transfusion, special risk if they are there like cardiac or any other associated disorder like diabetes, hypertension. So more important than the last couple of points is document the fact that the patient and relatives were allowed to ask questions. This is, I think, this point many of the time we are missing as a surgeons. We don't give them enough time to clarify their doubts, and these queries are answered to their satisfaction has to be mentioned in the informed consent. So I will give an example for first point of details of the disease. So I'm taking example of glioblastoma multiforme. So if we are operating on GBM patient, what has to be told to the patient? So we have to frankly explain the origin of the disease, what is the nature of the disease, how it spreads, and how it has affected to the patient's brain. Then there is high recurrence rate, there is reduced life expectancy, and this happens despite radical excision and adjuvant treatment. So overall prognosis is only partly depend upon surgical aggressive intervention. It is a tendency and nature of the disease which decides the fate. So all these parameters should be explained. This is, I'm just giving example of GBM. So whenever we have various options of treatment for a disease, for example, I am telling you example of acoustic neuron. So it just depends upon size and what the tumor is doing to the patient. But these are the three options available, like close observation, surgical intervention, and radiation. So we have to explain what type of treatment you would like to offer. And at the same time, you have to explain the pros and cons of other procedures. If there is no alternative to surgery, put it affirmly to the patient that there is no other option but to go ahead with the surgery. When surgical options are available, but there are more than one. So here I will talk about ACD or cervical disease, where we have both anterior approach and posterior approach. So we have to give in detail what are the indications, why we are considering anterior approach, and how safe it is to do. And the similar thing for posterior approach. So be frank about your expertise and experience, and what is your comfort in undertaking any approach. So everything has to be a part of consent. So possible complications, I usually explain bleeding, infection, neurological worsening, ICU stay, ventilatory support, and death. There should be no hesitation to convey death as a complication. Many times being worried about losing patient, many times we hesitate to convey those complications. So the second opinion is one of the important part of consent. This is my personal thoughts. How second opinion is important. It should be the part of consent. That's what I personally feel. It works dually. It increases safety for the doctors and it gives confidence and assurance to the patient. If the second opinion is in the same line of a primary consultant, that is affirmative, then you are sure that whatever you are doing is patient's thoughts are also in line with your thoughts. However, if it is a dissenting, for example, sometime it happens, we suggest surgery and somebody else is suggesting conservative line of treatment. So we have to mention that the second opinion of this doctor so has been taken, who has suggested conservative line of treatment. So it plays doubly, it makes sure that if something goes wrong, you have given enough chance for the patient to do whatever he wants to do with his body. So we are always safe. Even the opinion is in our, if it is in our line of thoughts, it is positive, and if it is against us, it is still positive. Consent in emergency has already been explained. So as a good Samaritan, we should not be waiting for consent in emergency. So video consent, already Londo sir has explained. Recently, there has been Gujarat High Court has given affirmative decision on video consent, especially with the hospitals who are running various government schemes. So most important part of the consent is things which are not documented have not happened. This is what happens in the court of law. Many times there may not be a negligence from the treating doctors or team of doctors or the hospital. Only we are falling short in the documentation. So we are facing the heat from the courts. So if the consent has been evaluated from no consent, that is the paternalistic attitude of doctors, to some amount of consent, then comes real consent, and then most important and current practice is written informed consent. So how the thoughts of doctors and patients have changed. So at this point of time, we are treating as a prudent patients. And in the past, it was paternalistic attitude of doctors. Then it became reasonable physicians. And now we are patient centric, and patient decide what patient want to go ahead with. Does consent provide full immunity to medical practitioner? The answer to this question is no. Now you will ask, why? Why so? Because in cases of a gross negligence, consent doesn't save you from the litigations and the court from the courts. So res ipsa loquitur is the most important legal maxim where the thing speaks of itself. So if you have these four things, the consent, whatever details consent you are taking don't help. So if you operate upon wrong patient, if you operate upon wrong side, if you are operating at wrong level, and if you are forgetting instrument or swab inside patient's body. So these are the really gross negligence. Even in Indian judiciaries, as a doctors, we should be able to clarify many concepts of the advocates and judges. There is always a thin line between negligence and diligence. So some doctors may feel that this act may be negligent, and some other may feel it diligent. So there are other parameters or other points which are also equally important. For example, error of judgment. So this is a very common problem. So if patient presents with paraparesis, as we know as a neurosurgeon, there can be a compressive element in the dorsal region or in the cervical, low cervical region, or there can be lesion in the high bifrontal parasagittal region. So all those lesions can present like same. So sometimes it can happen that we forget or we miss the diagnosis or miss the investigations. So known complications. So this is the second point. Many diseases, many surgeries have known complications, and those complications have been mentioned in the standard textbook, and there is enough literature in various journals about the same. So these parameters are very important. Medical accidents. Many times we perform some surgery. For example, we open for the case for some tumor, and suddenly there is a brain swelling, which is malignant. So you can't even touch the brain in that situation. So these are medical accidents which are beyond control of a treating doctor. And deficiency of services. So not necessarily that each and every case is a medical negligence. So these are all other parameters which can also take us to the court of law. And last is the vicarious liability. Vicarious liability means whatever is done by your subordinate or your nurses or your staff working in the hospital. So in conclusion, consent is a crucial part of the medical practice. It stands as a wall between doctors and prospective litigation. It gives freedom to patient to utilize the right of self-determination. It makes patient reasonably knowledgeable and prudent to take active participation in his or her own treatment. Thank you for your attention.
Thank you, Shashank. I think we will quickly go to Matthew's lecture before taking any questions. So, can I request Matthew to start your lecture, please?
Thank you. One moment. Okay. Can you hear me okay?
Yeah, you're audible and you're seen.
Fantastic. So many thanks once again for the invitation to come and talk with you today. My name's Matt Sanders. I'm the Senior Neurosurgical Registrar working in Sheffield Teaching Hospitals in Yorkshire in the United Kingdom, alongside my consultant colleague, Mr. Kishore Chowdhury. I'm here to talk to you today about the UK perspective of consent and capacity in the UK and how that applies to our practice here working in neurosurgery. I'm going to be talking about not just consent and capacity legislation as it is here in the UK, but also the processes, the practicalities, and how we can implement that day to day. I don't have any disclosures to declare. We can roughly define consent as the permission for something to happen or agreement for something to do things. But as my colleagues have just been talking about in some detail, this is a very, very simplified definition of consent, and clearly isn't something so simple that can be applied in the medical setting, particularly in neurosurgery where we're dealing with such critical structures. In terms of background, in the UK, if intervention and procedure is being consented for, the consent must be what we call an informed consent, i.e. the individual giving consent must have a full understanding of the procedure, its indications and its risks. Adults in the UK are defined as being 18 years or older, and they must have the capacity to make the decision for themselves. Capacity is defined by an amalgamation of multiple laws. Common law has been alluded to already, such as Montgomery, for example, as well as legislations, for example, the Human Rights Act and the Mental Capacity Act, which was established in 2005. The Mental Capacity Act forms the bulk of much of our work when it comes to determining capacity and consent to proceed for treatment. There are 5 guiding principles outlined by the Mental Capacity Act. Those are, firstly, the presumption of capacity. So that is, any adult must be assumed to have capacity until proven otherwise. Individuals must be supported to make a decision. So we must be able to communicate with patients in a way that they can readily understand the concepts that we are explaining to them, so that we are not using a sort of paternalistic means of consenting for their procedures. We have to respect individuals' right to make what we might deem an unwise decision. Now, if an individual has been found to have capacity and they are an adult, they are allowed under law to make what we might think is an unwise decision that may result in what could be considered a poor outcome. And patients that lack capacity, we have to act in their best interests. And the best interests is quite a loose term, but is if we're bringing together both our medical expertise, the patient's pre-morbid wishes, and those, and that can really be best determined by speaking to their relatives. And importantly, in patients that lack capacity, we have to utilize the least restrictive intervention possible. An assessment of capacity has got 4 key domains. First of all, a patient has to understand all the information relating to any proposed intervention. So they must understand all the risks and how that they may infer to them, or how that may impact them going forward, no matter how rare or uncommon. An individual has to be able to retain the relevant information long enough to make a decision relevant to the question being asked of them. Importantly, they do not have to be able to retain that information for a defined period of time, for example, from clinic through to being seen immediately prior to surgery. They only have to be able to retain that information long enough to make that decision at that point. The individual has to be able to weigh up the options that are available to them. Those can be conservative through to surgical interventions in our cases, and they also have to be able to communicate their decision. That can be verbal or it can be written, for example. Key here is that consent is not simply something that we obtain on the day of surgery when the patient attends for their operation. Consent, obtaining informed consent is a process, and it often begins when the clinician first sees the individual in the clinic to discuss the diagnosis and the various management options available to them. And one of the previous speakers spoke about Montgomery. So Montgomery versus Lanarkshire is a UK Supreme Court ruling from 2015 where all management options, conservative, less invasive through to most invasive, have to be taken into account, and the pros and cons of all of those have to be discussed with the individual. And again, the clinic is often the best scenario for that to take place. We often provide patients with supported documentation, be that prefabricated documentation and leaflets pertaining to the intervention that they may be undergoing. And it is now common practice in the UK for the pros and cons of each option to be set out in a letter, which would then be sent back to the patient, which they can refer to whilst they're going through the consent process and making their decision. And key thing is that written consent is obtained prior to undertaking of a procedure. And I will talk to you about, I'll show you an example of the forms that we use in the UK. So this is an example of some of the adjuncts that we can use in clinics. And on the left is a document on lumbar spine stenosis, which is produced by the British Association of Spinal Surgeons. And this is a relatively lengthy document, but is written in plain, simple English that the patients can refer to and understand. And this is available freely online for a multitude of spinal conditions. On the right, there's an example of some of the documentation that we produce for our patients here in Sheffield who have been diagnosed with meningioma, and that can include what they can expect on their management journey. And here we can sort of see that this is illustrating the process of consent starting in the clinic. There's an interplay between the various documents that we can give to patients to go and talk about so they can go away and think about their options. And actually, it's becoming more common in the UK to bring patients back to the clinic, to what we may call a consent clinic, to answer any questions and take written consent at that point prior to them actually turning up for their operation on the day of surgery, although this is variable. So in the UK, there are several standardized formats to facilitate documentation of an informed consent. And so in adults, so those aged over 18 with capacity to consent, we use a consent form 1. A consent form 1 is a standardized document, and this is an example of from a trust in the heart of England. However, all of these documents up and down the country are essentially uniform. So the name of the procedure is clearly for the patient to understand. The intended benefits are documented clearly and again in a way that the patient can understand. And then the significant, unavoidable, or frequently occurring risks are documented clearly. In my practice, I often talk through the procedure from start to finish as a useful tool to be able to say to patients what they can expect at each stage, and then talk about the relevant risks and how likely or unlikely they may be at each stage. I would then sign the paperwork, and to confirm their consent, the patient would also give their signature and date and print. A copy of this would be retained in the patient notes, and a copy of it is for the patient to keep for their records. Now, in our practice in neurosurgery, of course, a lot of patients unfortunately do lack capacity, be that for they have a long-standing medical condition or they have an emergency neurosurgical condition, which means they have a reduced level of consciousness, for example. And the Medical Capacity Act does provide legislation to help guide management of these patients. Critically, if a patient is unable to manage one of the 4 principles of capacity that I set out earlier, they legally cannot give their informed consent for the surgery. As a reminder, those principles are understanding of information relating to the proposed surgery, retaining that information long enough to make a decision, weighing up their options, and also communicating their decision. And if they can't do one or more of these, then they, by definition, lack capacity to consent. Now, in these scenarios in the UK, the clinician is empowered to provide an executive consent, providing that the procedure is deemed to be in their best interests. The clinician has to ideally consult the individual's next of kin where it is possible and appropriate to determine what the patient's best interest would be. It is common practice to involve other clinicians in this process. However, in some emergency scenarios, clearly this is not always possible. So where a decision to treat an individual isn't time critical, the Mental Capacity Act and the Powers of Attorney Act do set out legislative structures to help safeguard patients. So in the UK, a patient can have a legally binding document, formerly known as a living will, now known as an advance directive, where they can set out what their wishes would be in the case of them losing capacity. This may be, for example, an individual would not wish to have prolonged intubation if they were in a permanent vegetative state. This is a legal document and must be respected by the clinicians. Similarly, the lasting power of attorney for health and welfare is a legal document which is afforded to often a relative or a nominated individual by a patient to take effect when that individual loses their capacity to consent for matters regarding to their health and their welfare. So, for example, if an individual were to have an acute neurosurgery problem which meant that they lack capacity, the decision, their power of attorney for health and welfare would then have the legal right to make their decisions. And we as the clinicians would have to treat the decisions made by the individual, the lasting power of attorney, as if it were the patient themselves. And in cases where the courts are involved, they can also appoint a deputy via the Court of Protection. The Mental Capacity Act also sets out independent mental capacity advocates, or IMCAs, for those patients who lack capacity and who have no legislative or legally binding documents in place, or individuals who can be sought after to give an unbiased decision as to what they feel would be in their best interests. And also there's a structure set out called a best interest meeting, where a multidisciplinary team of clinicians, relatives representing the patient can all get together and decide what they think would be in the best interest of an individual, such as decisions surrounding additional surgery, withdrawal of life-sustaining care, for example. In these scenarios, we use a consent form 4, which is again a standardized document up and down the UK. Again, the name of the procedure is documented. We go through each section determining the patient's capacity and whether or not they have any legislative stakeholders who can provide information in their best interests that may be relevant to their upcoming surgery. And critically, as I mentioned before, it is the clinician that has the ultimate decision about whether or not to proceed in the patient's best interest, and therefore it's the clinician that signs the paperwork on behalf of the individual. Although, of course, we always seek out the support of relatives and or the clinicians where necessary. Children are slightly different. So in the UK, children aged under 16 usually cannot give consent for a significant medical procedure. And therefore, we often defer to an individual that has parental responsibility, or PR. In the UK, a child's mother automatically has parental responsibility at birth. The father of the child, or a female partner, also has automatic parental responsibility, but only if they are married or in a civil partnership with the mother at the time of the child's birth. Fathers who can gain parental responsibility when they are listed on the child's birth certificate. Other individuals can be appointed by a court or by agreement to have parental responsibility. And it's often only one individual with parental responsibility required to consent for medical procedures, unless there is a dispute between those with PR. There are some special cases with regards to children. So children aged under 16 may be competent to give consent if they're deemed to have sufficient intelligence, understanding, and they're of an appropriate age. We call this Gillick competence after the case law that first established it. Young patients, so those aged 16 and 17, are assumed to have capacity to consent. However, their decision can be overruled if it is not deemed to be in their best interests. And that can be overruled by a clinician or by someone with parental responsibility. In cases where an individual with parent responsibility is unavailable to consent in an emergency, then we as clinicians can provide consent, providing it's in the child's best interest. And like all of these frameworks, there is an established form called a consent form 2, which we use for managing consent in children. In the UK, patients are not legally able to demand treatment. Now, that has implications for when patients are at the end of their lives and clinicians are determining whether withdrawal of care or sustaining care is in the individual's best interests. So if it deemed to be in the patient's best interest, and this is almost always in conjunction with the next of kin, clinicians are legally empowered to withhold life-sustaining care, such as nutrition and ventilation in patients who are in a permanent vegetative state. This was established in the UK Supreme Court back in 2018. Patients who have mental capacity to do so can decline treatment even when we deem treatment would be in their best interest. And this is a reflection of the Mental Capacity Act, where patients are empowered to make what we may think of as an unwise decision, providing that they fully understand and have capacity to do so. We formalize these decisions in a form called a respect form, which essentially details what a patient's wishes would be as they approach the end of their life. This may be, for example, cardiopulmonary resuscitation, or whether they would value interventions such as prolonged ventilation, for example. However, importantly, these are not legally binding documents. This is an example of the respect forms that we use in the UK. And this essentially is a guide for clinicians when an individual may come into hospital as to what their wishes may be in a scenario where the patient may be coming towards the end of their life. So, in conclusion, it's important to note that consent is a process and is not a single event that we obtain immediately prior to surgery. In the UK, adult patients must have mental capacity to give consent, and all adult patients are assumed to have mental capacity until they are proven to not have it. Clinicians can consent on behalf of patients who do not have capacity, providing it is in their best interests and where necessary, for example, time-critical neurosurgical emergencies. Children who are aged under 16 often require consent to be given by someone who has parental responsibility, often a mother, often a father. The limits of care can be put in place by clinicians where management is not deemed to be in the best interests of the patient. Thank you very much.
Thank you for excellent lecture, Matthew. And thank you for joining us and enlightening us about what laws are prevalent in United Kingdom, because we can always, take a leaf from someone else's practice. So, can we take some questions, Sarang? Do we have time? Take questions.
Yeah, we'll go ahead, sir.
So basically, let me ask a question to both Dr. Londe and Dr. Shashank Joshi. You have beautifully outlined what needs to be done, but my question is, when we do it, what proves that to the court that we have done it? It is just the documentation. For example, if I write on the consent that I have explained all the alternative treatments to the patient, is it good enough, or I have to, in detail write about it?
You have to write the various options. That's what. If we are suggesting open surgery, for example, somebody is asking about spine surgeries like MISS or endoscopic procedure or microscopic procedure or open laminectomy. So these are 3-4 options for any spine disorder. So in those situations, you have to mention that these are 3-4 options available, and you have to write about individual advantages and disadvantages of each procedure. And
it will become a very big document.
That's what it will become a document, but that's what it is. If you have a good document, it will save you in the court of law.
No, I agree. But if you imagine our daily routine, and you are saying that each consent has to be taken as a individual case and not in a pre-filled form, something
Yes.
like that.
See, till
Then, I
now,
mean, it will be like writing an essay every time that
not necessarily to be an essay, but important points has to be mentioned in that.
not enough to just say that, we
Yeah.
have discussed and we
Yes.
have explained. It's not enough.
See what
You have to
happens.
write what you have explained.
Yeah. See, what happens is once you or anybody discusses so much with the patients, many times they understand, and some patient may not understand. But then you have to reiterate the things. That's why I have mentioned about taking 2 consents at the span of 12 to 24 hours, so that we have given enough time for them to understand.
So isn't video consent the best via media for this?
Yes, it is. Now it is going to be a boom. It is more helpful into the court of law.
Because nobody can deny that I was told such and such a thing.
True.
Can I interject there, and can I
Yeah.
say what we do for all the spine patients, elective spine patients? What we do is when we explain to them, not only we hand over the leaflet to them, I also, as soon as the patient is gone, I also dictate a letter saying what we have given, what we have told them, who was accompanying them, and what options have we given them, and whether the patient has agreed to undergo the procedure or not. I dictate a letter with a copy to the patient and a copy to the GP and copy to the referring clinician and a copy for our record. Now, when the patient gets that copy, and if they don't agree with something, they can always come back to us saying, look, you said this, but this is not true. And that remains a record in the patient's file, so that if patient actually comes to surgery, they have had time to read it, understand it, reflect it, and ask any questions. But in the process of consent or on a consent form, as Jaydev you say, it is impossible to write all the options and all the pros and cons of each options. It is impractical. So this is what we do. Every time a patient is seen, I dictate a letter that goes in the system and goes all to stakeholder parties. So that becomes our proof. Like, look, I told you this. And if they don't come back to you, then they say, look, if there were any questions or if something you didn't agree with it, either you could have come back to us or you could have gone to your GP or you could have asked on the day of surgery, but you didn't. So you agreed with whatever we said. Does it make sense?
Yes, of course. Yeah. So basically what happens in my opinion, if you explain to the patient and their relatives in detail in the first visit or first setting or first time when you are taking consent, probably when you are discussing same thing, but you don't require to explain it in that great details. So you can concise the discussion to certain important points, which are probably like a real consent.
No, my question is, presuming that you have done everything, what proves in the court that you have done it? That's my
Only
question.
documentation, yes. Only documentation will prove.
Okay.
The other problem that comes is those which are rare complications but are life-changing complications, such as injuring a vena cava or aorta during lumbar disc surgery, which happens, or injuring a vertebral artery, spinal cord during spinal cervical spine surgery. Again, it does happen. We've all seen it. Or injuring the esophagus and patient having problems after that. So what we do is we not only dictate, and we also say that rare but life-changing consequences such as inferior vena cava injury, great aorta injury are very rare, and the incidence is what, 1 in 10,000 or 100,000, but we have mentioned it and the patient understand it. So actually, when in a webinar on cervical spine, I said that every patient should be explained about paraplegia and esophageal injury and vertebral or carotid injury. And in the webinar, one of the speakers says that, look, Kishore, you are sitting in the UK. If you are sitting here in private practice, and if I tell them about paraplegia and death, no patient will undergo ACDF from my hand. Now, that may well be true, but then if all of us follow the same standards and are uniform in giving the complications to the patients, then patients will understand even if they take a second or third opinion. And I think in the wider context, it would be rather easier for me to lose a patient if they don't want to hear those complications from me, rather than me not telling them having a complication and then me getting into trouble. Does that make sense?
Okay.
Yes, yes.
Yeah.
So better to prevent complications rather than getting out of complications. So similarly, preventing the litigations rather than coming out of litigations. So
शहाण्याने कोर्टाची पायरी चढू नये म्हणतात तसं.
yes, yes.
Can I have some input?
Yeah, please.
Yeah, I think we just heard both Dr. Shashank as well as Dr. Kishore, but practical part of it is definitely it is going to be a very huge voluminous document.
Correct.
Frankly speaking, what is more important is merely to convince the judge that you have discussed the various options, and therefore.
So how do you do that? That is the question.
Yeah, I'm coming to that point, that whatever are the documented options available in our practice of neurosurgery for treatment of that particular condition, even if the mention of that is made and you don't mention in detail the problems and associated complications of those procedures, for instance, whatever you may be wanting to do for a herniated lumbar disc, whatever be the procedure, if you just enumerate the other procedures, that is enough. It is not mandatory for you to go into the complications of the enumerated procedures. But whatever procedure you are going to do personally on that particular patient, that has to be discussed definitely in detail regarding whatever are the complications of that. That part has to be done. But the other procedures, you may have to just document it by enumerating it. And that has been conveyed to the patient, and that's it. I don't think one has to go into a large volume of the way in which is the practice in UK or maybe even in the US, because or our judicial system, I would say, is not that categoric in enumerating on paper the various details which are to be mentioned like in other countries. And each country has its own law and its method of interpretation, which is separate and which is not the same everywhere else. So I think one has to be just sort of, logical in documentation. That's it. Not too detailed about it. Thanks.
I think
thanks. Something to
Prablesh has got something to say as well.
Just to add to something to what Kishore says, here we don't dictate or write letters to GP, but I think the alternative thing is to mention everything in the notes. Just you have discussed the different options, though you don't mention it on the consent form. So that is also taken as a valid, because you have documented what you have discussed with the patient and patient's family about the different options, and you document in the patient's notes rather than on the patient's consent form.
So the problem with that is, Uday, that you might write that you explain to the patient, but the patient might deny. So that's why we send a letter. And nowadays it's a law to copy every letter to the patient, so that then they cannot deny that they read it and understood it.
I understand.
And the other thing that we always face is that who can consent? Now, in private practice, where the consultant is always there to consent, but otherwise, in teaching institutes, for example, simple procedure like carotid angiogram or DSA, who can consent? And the law here states that anyone can consent who understands the procedure and who would have explained in the same way the risk and consequences of that procedure as the operating surgeon would have explained. So that is the reason. So if my registrar Matthew Sanders can understand and can explain in the same way that I can explain, then he can consent the patient for any procedure, including clipping of an aneurysm. And it does happen that they consent for us complex aneurysms, acoustics, clival chordomas, clipping of aneurysms, resection of AVMs. We are okay for registrar to explain as long as the standard of explanation and the understanding is the same as where the consultant would have explained.
Now, I will tell you something. What happens in India, it is routine problems for most of the practitioners. They hardly find time to talk to the patients, their relatives, and many times everything has been discussed in the OPD or it has been discussed during pre-admission process. And on the day of admission or on the day of surgery, if a nurse is taking the signature, then probably that point they hold in the court of law, and then probably we find ourselves less or weak in proving that you have explained in great details and or the consent has been taken properly. So they always put pressure. They give importance to the signature, who has taken the signature, rather than the complete process. So I was always mentioning that this is not a one incidence which is called as consent. It has to be a process from your first consultation till the procedure is undertaken.
Where
So it means that you have to take the consent yourself every time. That's what it implies.
Yes. In fact, in our in Hiranandani Hospital and Nanavati Hospital, without signature of a consultant in the consent, the patient is not shifted from the ward to operation theatre, and probably that is one of the best steps to prevent those problems.
Can I just highlight on one point here? There was a case from Sri Chitra, and in that case, the decision which the Supreme Court made suggested that the consent has to be taken by the operating surgeon in India.
Yes.
So which means that on the consent form, apart from the signature of the patient and the relative, it is also the operating surgeon who needs to sign. That is one point. Second thing is that particular case, the directives given were in addition was that the patient should be made aware of who the assistant surgeon is going to be, who the nursing staff is going to be, and who the anesthetist is going to be. So the patient has to be introduced at least in name as to who the operating team is going to be in complete. It's not just the operating surgeon, but it is also the assistant and staff who's the first nurse to the surgery, as well as the anesthetist. So I would suggest that these points should be kept in mind while consent is taken, because in India it differs rather than what Kishore just suggested, that in UK maybe the registrar can take consent for the consultant, but that is not the case in India.
So, Nitin, my question is, if in the OPD, maybe 2-3 days before you actually operate, sorry, and you are talking to the patient and then you are telling the risks and everything, and if you are recording it on the video, does this supersede a signature?
No. Today, no. As of today, no. As of today, a written document.
So it's a direct evidence that you're telling the patient.
Yes, as I just suggested, that a digital evidence is not under law. It is only under the Indian Evidence Act. So it depends upon under which act and under which provision the doctor is being alleged. You understand? Sorry.
Sir, I personally feel that till now in India, whatever laws are used by the various lower courts, these are all case laws. Case laws means whatever Supreme Court gives a judgment becomes a law for the entire India. So most of the medical legal cases which have been judgments have been passed by Supreme Court, those are considered by us as a law. There is no law which has been made by the legislation. So probably if legislation law is made, maybe in the future, probably that will help us in providing these consent forms the way one of our presenter was showing about form number 1, 2, 3, 4. Probably similar thing can be done, and legislative law is the best law. The case law is always, there is always
well-defined
discretion and thoughts of a judge, because
what
the judge has to listen both sides, and probably till he listens completely from the both complainant and defendant. So till that he is always have thoughts of 50-50. He thinks from both sides, but at one point of time he will suddenly change the percentage. On one side it will be 49%, and the other side he will think as a 51%. And most of the time in consumer courts, the courts are tribunals, so they have to take consumers side more than doctors or service providers side. So in those situations, the case laws are most of the time they go in favor of patients. So many times, if you see the judgments of the lower court, that is consumer courts, is many times they go in favor of the patients. However, 97% of those decisions have been overturned in the Supreme Court simply because of all those other Indian Evidence Act, all those procedural acts they are following in the Supreme Court. And these tribunals are not responsible, or they are not supposed to follow all those things just to facilitate and expedite the case.
As we are overshooting time, I request Dr. Pragnesh Bhatt sir and our panelists to make a comment each, please.
Kishore, would you like to speak about it?
The thing is, what we can copy from UK practice to Maharashtra practice is, I think, the crux of what I wanted to say. One thing is, the British neurological surgeons and British spine associations have prepared excellent leaflets which are in plain English terms. We can copy them as they are, and they can be used for routine procedures such as simple craniotomy for a glioma, meningioma, spinal procedures, and they are very helpful. And we use them left and right for every patient. And something that we can copy, we can in fact translate them into Marathi and Hindi as well, as far as Maharashtrian practice is concerned. And second thing is, what Matthew showed us, the form, they are not my forms or our form or departmental form. They are agreed nationally, and there is nothing wrong with something similar that we can have on our website MCNS, where any consultant can just download them, print them, and use them rather than just using paper format.
Correct. See, it will evolve as one of the answers for the apprehension that many doctors have, that if I start, talking about all the complications, the patient can run away. This is one of the things that is, brewing in one's mind. So everyone starts doing the same thing. It becomes a procedural thing, and then one can say that this is a
That is what upgradation of our thoughts, upgradation of our clinical practice is essential now. You cannot just say, okay, nothing will happen, I mean.
And you know what? The problem in India is that sometimes patients think that the doctor is not telling us all the complications because they don't want to lose the patient. It is patient's perception also that we need to change. And this is only can be done if our standards are uniform across the board among the neurosurgeons.
Yeah, correct. Agreed.
The only issue is we are discussing amongst us, and there is no person from advocates or judges who are important people in final decisions. So whatever Dr. Kishore Chaudhary was saying, that these all 4 or 5 formats, whatever they have, probably that can be utilized in India with legislative law, probably ultimately. That should be, considered.
Yeah, it will require a lot of activism on the part of, we need to involve some retired judge or, someone who holds a very high esteem in general in national. For example, a retired CGI who is interested in doctors' problems. I'm giving an example. And if someone knows them personally, we can hold seminars.
Sir, many times what happens is these discussions, they go to law commission, and then law commission to take the efforts to prepare drafts for these things. And probably the legislation is the best solution. So, it will be uniformity all over the country. And most of the doctors will get rid of these difficulties, which you are facing simply because of there are case laws, and the case laws are different from state to state. The case laws are different from because of different judges think differently. So all those parameters can be nullified by a proper legislative act.
That's right.
So on this note, shall we call it a day?
Sorry, we want Ashish to speak as well. Ashish.
Yeah, Ashish.
Yeah, yes, sir. So I had 2-3 questions, sir. One was whether a written consent is more important than a printed consent, or vice versa.
You mean handwritten consent?
Yeah, handwritten consent.
Handwritten by whom?
Written either by the doctor or by the patient's relative.
At this point of time, if you have a written format with the space for the things to be written, it is still acceptable because the matter is sub judice in the Supreme Court. If Supreme Court says this is not acceptable practice, then we will have to cancel that, and we will have to change our way of taking medical consent.
So you mean to say printed
format with space
with
for possible complications, alternative treatment, all those things, all those standard in format of informed consent should be there in that form.
Okay.
Unfortunately, what happens is the consent form are different from different hospital. Like if your
Right.
hospital is having one consent form, it may not be similar in with my hospital. So probably that is another issue. So what we can decide is whatever points we have discussed, we should include those points in that printed form, and we can keep space for possible complications so that it can become more procedure specific rather than a blanket consent.
As rightly said by you all, I think a uniform consent would be a better idea for everybody of us. And the consent will every consent is gonna echo the same problems. So I think the trust factor of the patient is gonna be more with such uniform consents.
See, Ashish, just to inform you about the point,
Yes, sir.
the consent will have two parts. One is the standard format, wherein it is procedure specific. That means whatever procedure you are doing will have a standard set of problems associated with it, which needs to be conveyed to the patient. That has to be documented. So that is procedure specific. And the second part of it is patient specific. So the individual patient whom you are treating will have some medical problems, will have some other associated problems, which can create further complications post-surgery or maybe during surgery. So that also needs to be included. And therefore, as it stands today, as what Shashank was saying, the standard format of printed format of a consent is considered as a standard contract, which is not as acceptable in the court of law as a individualized consent is. And therefore, that case which is sub judice, Vinod Khanna versus that we all
Yes, sir.
clinic, and it is being contested by an advocate by the name of Bajpai. So as it stands today, what court has said is status quo. They have not given a decision on that. So what they have said is both the types of consents presently are applicable or are acceptable. The only thing is that for safety reasons, I would suggest, and which I have a practice of doing myself, is have a standard format taken as a standard procedure related complications consent. And the other is a handwritten format, which is more of a patient related specific complication consent. So that is my practice. Individual persons can have their own outlook and make a decision accordingly.
Right, sir. And secondly, like there are patients who won't understand, like if they are signing in English, probably it won't matter. But if they're signing in their like Marathi or Hindi, then do we have
let me answer this question more because it is important. See, most of the people who are illiterate also have a tendency to sign on checks in the bank in English. Their name. They can just identify the letters of their name. That's it.
Right,
but
right.
that does not mean that they understand English. Okay. Therefore, when consent of such people are taken where you feel that the language in which you are communicating with them is not the language which they understand, you have to have an interpreter in between. And that person also has to sign on the consent, suggesting that he has conveyed what the doctor has told the patient in a language which he has understood. And therefore, ultimately, when the patient signs, the one of the last lines which is there on that consent is, I have understood all the above which I am consenting to, in the language in which they understand. Now, whether it is English, vernacular, Marathi, Hindi, or any other language, I cannot make a suggestion on that. But by and large, in Maharashtra, it is either English, Hindi, or Marathi. That's how it is.
So if the patient is unable to read,
then it has to be communicated through an interpreter.
So who can be an interpreter?
The immediate relative.
Okay.
Who's literate.
Okay.
And another thing was, there was a sentence out there that witness consents are more dependable.
Yes. I didn't get the point, sorry.
Witnessed consents are more dependable, basically.
Yeah, witness is necessary as a third party to sort of,
Yeah, so can a nurse or a doctor can be a witness, other doctor from the hospital?
Preferably not. Preferably not, because he will speak in the language of the hospital or the doctor who's accused. So it is always better to have someone from the relations side.
Okay, like another relative, basically.
Yes.
So what I have suggested, one witness from patient side, one witness from hospital side.
That is also fine.
That will be a better
more
approach.
important is from the patient side, because they are the people who are going to be accusing.
Right.
In our practice, we are not allowed to have a relative as an interpreter, because there could be a potential conflict of interest between the patient and the relative. So all the hospitals in the UK have something called as language line, whether you dial a number and then you enter the hospital code, and then there is a list of some 186 languages that an interpreter would be available to us. Because even if people are living in the UK for 30 years, especially from our neighboring countries, but they are not able to speak a word of English, and that does happen. Plus the Eastern European people. So there's always a problem, but we are not allowed to have relative as a interpreter for number of reasons.
But I'm quite surprised, Kishore, because in India, if the relative can be signing for the patient on the consent, in case the patient is not in a position to do so, then if this is acceptable in India, I'm not sure how or what the status is in the UK. Can the relative sign on behalf of the patient if the patient is incapacitated or incapable of signing or consenting?
No, it's the doctor who signs on behalf of the patient.
Okay. So it is not the relative.
No, relatives are never allowed to sign.
Here, the primary person after the patient is the immediate relative, and it is by law an acceptable relation, except for in-laws.
Yes, that's understandable.
Is there any place of having a legal person like a notary in the hospital?
Yeah, I was about to come to you, because during recent 6-7 years of my medical legal discussions, my advocate was always in the opinion that, doctor, you start taking consent on legal papers, bond papers.
Why not? I'm asking why not? Because some legal person will sign on that as a witness.
So that ultimately, probably, if we don't have any legislative law, probably it will ultimately end up in doing that.
Sorry, Pragnesh wants to speak something. His hand is up for quite some time. Pragnesh.
Thank you very much. Very interesting webinar. I have woken up at 4 o'clock to listen to, because I'm interested in this subject. Coming back to the last point, for Jehovah's Witness, usually there is a representative from their faith available in hospital to help consent regarding blood and blood products or alternatives. That's number one. My experience in and interest in this started from my time in JJ Hospital way back in mid-80s. And I would say we have discussed legal aspect, but I would bring another aspect. In my practice, I consent till today 75% of the patients myself. And do you know how much time I spend for consenting average operation? I'm not talking about like clipping of aneurysm, but an average operation, minimum half an hour, but usually for malignant brain tumors like things, 45 minutes. And I would say it is a very good investment. I know you may say we don't have the luxury of time, but I have practiced for 10 years in Ahmedabad, and I used to put in practice everything that has been discussed in the language that they understand the best, starting with the anatomy, physiology, pathophysiology, alternatives of treatment, no treatment, and pros and cons of each options with likely complications in the language they understand, tailor-made for each individual patient. And I must say, having worked in 3 continents, I have had very low complication, litigation rate. Only because I believe this is the best opportunity to establish a rapport, and I usually have 3 to 4 ingredients. Always a relative present next of kin, usually, always a nurse or a junior doctor present, always images, always model, and give them enough information, enough time, enough privacy. And it is a process, all the fundamentals that have been mentioned by all the colleagues. I must say, my practice started in JJ, and I thank Dr. Palande to instill the initial legal concepts. And lastly, they were fundamentally solidified by one senior consultant, Kishore and Matthew may know from Sheffield, Robert Battersby, who had a huge legal practice. And the 3 things I start with related to anesthesia, infection, and bleeding, and I end up with paralysis, coma, and death. Thank you.
Thank you.
Yes, sir. I think we have overspread our time.
Okay. So shall we stop for today?
Yes.
Thank you.
It was a good meeting.
Thank you, everyone.
Thank you. The next meeting is April 24th next month. April.
Right.
Last Thursday. Yeah. Bye.
Thank you, everyone.
Right.
Good
Thank
night.
you.
Thank you so much. Thank you.
Everyone.
Thank you very much.
Thank you.
Be patient. Yeah, see what you do.